Hello, everyone. I am Pragati Hebbar from the Institute of Public Health, Bangalore, a PhD scholar and a Department of Biotechnology Wellcome Trust India Alliance Fellow. On behalf of the Institute of Public Health, Bangalore, I'm delighted to warmly welcome you all to our Annual Day Oration 2020. IPH was started in 2005 by a group of committed healthcare professionals, by a small group, with the main vision of providing a platform to young healthcare professionals to build their skills and also strengthen the Indian healthcare system to ensure quality healthcare to everyone and especially the poor. And we have been working at the academia and bridging it with practice. Over the last 15 years, IPH has driven over 100 projects, especially under the domains of research, education, and policy engagement. And we have an alumni base of over 800 individuals across the globe. It has indeed been an enriching and truly humbling experience, to say the least. Albeit, the journey was and has not been without struggles. IPH started the Annual Day Oration series in 2018 to listen and learn from inspiring leaders in the field of public health. Our first oration was delivered by Mr. K.V. Dhananjaya, a Supreme Court advocate, in 2018, and the second in 2019 was delivered by Dr. Ravi Narayan, a senior public health researcher and activist. And this year, we are privileged to have amongst us Dr. Gita Sen to deliver the Annual Day Oration. Before I introduce her, I would like to share some points to help us make the session engaging. Participants can view the oration through this YouTube live link, and you can engage via the chat box on the right-hand corner. To be able to chat, you need to have a Gmail account and also create a channel. And in this way, you will be able to engage with us. Please share your comments, reflections, thoughts, and any queries. At the end of the talk, we will be trying to take as many queries as we can, depending on the time available. Now, I'm pleased to introduce Dr. Sen. Dr. Sen is a distinguished professor and director of the Ramalingaswami Center on Equity and Social Determinants of Health at the Public Health Foundation of India, and adjunct faculty at the Global Health and Population at Harvard Chan School of Public Health. She has a PhD in economics from Stanford University. Her work has helped advance gender equality and women's health through a variety of previous positions, which include the co-coordinator of the Knowledge Network on Women and Gender Equity for the WHO Commission on Social Determinants of Health, member of the recent Lancet Commission on Women and Health, of WHO's Advisory Committee on Health Research, of the UN's High-Level Task Force for the International Conference on Population and Development beyond 2014, and co-chair of the Pan-American Health Organization's Technical Advisory Group on Gender Equality and Health. In India, she has been a member of the governing board of the National Health Systems Resource Center, the Mission Steering Group for the National Rural Health Mission, and the High-Level Expert Group on Universal Health Coverage, set up by India's Planning Commission. She is currently co-chair of the Gender and Rights Advisory Panel of WHO's Department of Reproductive Health Research. She is on the Independent Accountability Panel for the UN Secretary General's strategy, Every Woman, Every Child, Every Adolescent, and is a member of the Lancet Commission on Synergistic Approach to Universal Health Coverage, Health Security, and Health Promotion. Her books include, inter alia, Remaking Social Contracts, Feminists in a Fierce New World, Gender Equity in Health, The Shifting of Frontiers of Evidence and Action, and Women's Empowerment and Demographic Processes, Moving Beyond Cairo, and Population Policies Reconsidered, Health, Empowerment, and Rights. We are truly privileged to have you amongst us today, ma'am. And with no further ado, I request you to deliver the IPH Annual Day Oration 2020, Inequality, Biopower, and Health, a Perfect Storm. Thank you, ma'am, and over to you.
Thanks very much, Pragati. And let me start out by thanking the Institute of Public Health for the honor of delivering this annual day oration. I know how much it means to you, and so I'm really both humbled and happy to be here with you. As always in these COVID time Zoom webinars, it's strange to be talking to a camera and oneself without having the advantage of seeing the faces and reactions of people as they hear. But be that as it may. I'm assuming that many of the people who are listening are people who have some connections with public health of some kind, at least the majority of you. So I'll not be taking a lot of time to detail facts about health inequality in the country, which most of us are quite familiar with, although I will focus on a few things, as you'll see. Instead, in this talk, what I want to do is to step back to a few more basic questions. One set of questions is why in 2020, almost 3/4 of a year, 3/4 of a century after independence, is our health system so weak? Why are health outcomes still so poor? It's not for want of trying. And why is health status so unequal and so abysmal at the lower ends of that inequality? Or I should say those inequalities. One needs to go no further than looking, for instance, at any indicator. Take child stunting, for instance, stunting among children under the age of 5. We still have about 1/3 of children under 5 who are either moderately or severely stunted, and that rises to nearly 50% in Bihar and UP, as compared to about 20% in Kerala and Goa. It's again about the same 50% in the poorest wealth quintile, and a child in the poorest wealth quintile is twice as likely as one in the highest wealth quintile to be stunted. And the same 50% holds when you are a child of a mother who has no education. Among Dalits and Adivasis, the stunting rate is around 40%. And that is 3/4 of a century after independence, and much talk and many programs later. Now, stunting, as you know, and these numbers really have to do with height for age among children 0 to 59 months old. When the height for age is 2 standard deviations below the median, you're supposed to be moderately or severely stunted. And that's what we're talking about here, 2 standard deviations below the median. And what stunting does to it is that it dramatically worsens a child's learning abilities, and therefore the child's ability to stay on with education, future economic prospects. Not to mention, stunting also is connected to higher future risks of such things as diabetes, hypertension, obesity, and so on. Among the factors responsible for stunting is undernutrition and anemia among adolescent girls, who then, when they are married and bear children early, end up producing underweight and then low height for age children, stunted children. That India accounts for 1/3 of the global total, about 41 million children. And when we look at the wasting data which is weight for height. About the 15% is the rate, 25 million children, and that's 5 times worse in the lowest wealth quintiles as compared to the highest wealth quintiles. Now, the government, as we know, has tried many different things, nutrition schemes of different kinds, the most recent one being the Poshan Abhiyan. But particularly in the last few years, the rate of decline in stunting has actually slowed down. And that's a cause for deep concern. We need, therefore, to understand why it is. And I'm just using stunting as an example. I could give you many other kinds of data on health outcomes, health status, and health inequality, which would all more or less give us a similar, though not obviously not identical, set of numbers or identical picture. We need, therefore, to delve perhaps more deeply into how we understand inequality. And obviously, in saying this, I'm putting my finger on inequality as being one of those distal but highly important reasons for health status and health outcomes. Before we get to that, however, let me say what the second question is, and that, of course, is what may have intrigued you in the title for this talk. What is biopower, and how is it related to inequality? And why do I call this a perfect storm? So without more ado, let me get into the substance of what I have to say. Inequality. Growing concerns about rising economic inequality as the sheen has worn off neoliberal globalization is to be found everywhere across the world. Certainly among academic writers, you find it in the work of people like Thomas Piketty, Joseph Stiglitz, Paul Krugman, and a whole host of others, including Indians, who are deeply concerned about growing economic inequality. The impact of economic inequality on health is something that's actually been studied over a much longer period, over, I would say, more than a century at least, going back to the times, now I'm speaking globally, going back to the times of the Boer War, when English army recruiters were horrified at the terribly debilitated and weak conditions of the potential recruits who would show up for medical examinations before joining the army. The rising public health agenda, immunization and antibiotics, as well as improvements in sanitation, hygiene, nutrition, and so on, all took implicit recognition, at least, of the effect of poverty. Poverty, though perhaps not inequality, because the early part of the 20th century was still the era of colonialism in its heyday and of other such forms of unequal thinking, such as eugenics, etc., to which we'll come back in a little while. But the impact of economic inequality on health, certainly with Alma-Ata in the late 1970s, and then the rise of the people's health movement pointing to the deleterious effects of inequality, the setting up by the World Health Organization of the Commission on the Social Determinants of Health, all of these were different ways, not always ideal, but ways in which the reality of economic inequality and its impacts on health could not be denied. The question, of course, is, was the effect on health because of poverty or inequality? Was it the level of poverty, the level of income that was the problem, or the extent of inequality? Now, we don't actually have a lot of work on this question, but one at least which was among high-income countries is the work, of course, of Professor Richard Wilkinson and Kate Pickett. In 2010, they published a book, The Spirit Level, that many people probably know, which looked at 21 high-income countries and which found that performance on health and a related set of social indicators, indexed social indicators, was linked not to the level of income, but to income inequality, the extent of income inequality. That is, the more unequal countries among these 21 were much worse off in terms of the indicators than the ones that were not so unequal. Whereas the level of income hardly had the same kind of effect. In fact, it did not have an effect. Now, why did Wilkinson and Pickett only look at high-income countries? Because obviously you need to have some amount of comparability. Obviously, if you take Switzerland and compare it to Burkina Faso, you're going to find that the level of income makes a difference. And of course it will. But the point is, in terms of public policy, once you've reached a certain comparable levels, what is it that really works and what is it that really matters? So Wilkinson and Pickett's argument, at least, was that income inequality was more critical than the average level of income in determining what happened with health indicators, as well as a range of other social indicators as well. But the question then, a second question arises out of this. But what about other forms of inequality? Wilkinson and Pickett's work, as with much of the other work on inequality by economists, is focused on economic inequality. Other forms of inequality, social inequalities, are usually much less recognized, including in terms of their effects on health, much less studied, and much later recognized and studied. In this context, I would argue that the effect of different kinds of social inequalities on health varies, and depends very much on what one might call the society's original inequality sins. What's the original inequality sin in a society, or sins sometimes? For example, if you were to take the United States, its original inequality sins are obviously slavery and related and ensuing racism and genocide against Native Americans. If you look at Canada, Australia, and New Zealand, what they did to indigenous people and the consequent huge social inequalities within society permeated, and society as a whole spread into economic inequality, but in fact operates independent of economic inequality. If you move to Central and South America, again, you find varying combinations of toxic mixtures of slavery and indigenous people being expropriated from land and means of production. The work of people like Nancy Krieger, and more recently, the work of a number of people on intersectional inequalities, has challenged approaches that look only at economic inequality between households when studying the effect of inequality on health. Even when they those who look at economic inequality between households quite often treat it as though it is uniformly or randomly, not uniformly, randomly distributed across the population. But we know that economic inequality is not randomly distributed across the population. In fact, it intersects with different kinds of social inequality. So what does all this have to tell us about India? What about India? One of the things that we do know is in recent times, and certainly since the period of the liberalization of the economy and our move towards very rapid economic growth, we've also seen huge increases in economic inequality. When I was working at the Center for Development Studies in Trivandrum back in the 1980s, one of the things that Professor K. N. Raj used to say at the center was that in India, we don't have the kinds of toxic inequality levels that you have, say, in Latin America. Take a country like Brazil. We know now that that accolade would no longer hold for India. India is one of the most unequal economies and societies in the world today. So what about the effect of inequality and the rising inequality on health in India? Before I get into that question, let me just say something about health inequality per se. One can argue that there are three ways in which health inequality manifests. One is through health outcomes. The second is through vulnerability and risk due to social determinants of health, which determine such things as housing, access to clean water and sanitation, but also such things as gender, caste, religion, and so on. And a third way in which economic health inequality manifests is inequality in access and affordability to preventive, promotive, curative, restorative health services. So there are really three ways in which we can look at and think about health inequality. And social inequalities play a role in all three. And that's what we need to be aware of. Now, in the Indian context, our original inequality sins are not the sins of slavery, but they are certainly the sins of caste, of gender, and of religion and disability, though those have varied over time and become more exacerbated in recent times, perhaps. All three manifestations of social inequality can be found if we look at these, which are our societies. And I use these words with great care, our society's original sins. They are sins that we have not gotten rid of, and they are sins that permeate, whose effects permeate everything in society. Now, we do know that if we were to look at economic versus social inequality in India, economics can sometimes override social inequalities. You can look at a particular health indicator and find that when you put together a multiple regression with caste and economic status into the mix, that the importance of caste might reduce and get completely overshadowed by the economic differences. That's especially true for caste in urban India, but it's certainly not always true, not true in the rural areas, and certainly not true for gender. For example, the stunting that we spoke about, stunting differences by gender are important and continue significant. One of the most striking experiences of the role of social inequality that I and my team had in our work in northern Karnataka was when we found, and we were working, our work was related to maternal health and particularly prevention of maternal deaths in those days of the 2000s. And we found that this adolescent girl had died, but that she came from a relatively well-off family. There was no economic reason why this girl should not have received better care than she did in her pregnancy. But she didn't. And she didn't largely because the household really was either oblivious or uncaring to the gender implications of her situation as a young pregnant girl. So gender inequality, and we've had many other pieces of evidence and experience which tell us that gender inequality sometimes actually overrides economic inequality. Another example from our work again is the fact that when we were looking at large survey data on discontinuation of care in a person for patients who had already begun getting care, why did they discontinue and when they discontinued? If we left gender out of the picture, and if we didn't do a proper intersectional analysis, we found that it was the economic inequality that mattered. Poorer households did much worse than better off households. But when you throw gender into the mix, what we found was that it wasn't everybody in the poor households whose care was discontinued. There was a huge gender differential between whose care was discontinued. The discontinuation was much greater for girls and women than for boys and men. So while men and boys were able to hold on to what they had, girls and women could not. And in a sense, whatever household resources were there, the limited resources that had to be rationed, if one wants to think in those terms, were being rationed in favor of the male gender. The poor acknowledgement of the social bases of inequality by public programs then means that in fact we can allow such masking factors, such differentials to remain unaddressed, and instead of which we largely try to substitute other proxy variables for social status. In the country, there are two such that we use all the time. One is geography, which gets substituted for social status. So we have high focus districts, we have high focus states, we have C category districts, so on and so forth. The terminology, as we all know, has changed continuously over time, but essentially it is replacing geography as though everyone in those areas, in fact, has a problem. Secondly, economic over social inequality, proxies for social inequality when through the use of BPL, below poverty line. But it's not, as we found in our work on poor households, it's not everybody who has the same problems or gets dealt with by households in the same way, even within poor households, and not within richer households either. So social inequality, unless it is directly addressed, if it continues to be addressed through such proxies, tends to slip through the cracks. Now, in our context, we know that feminist thinking has, and women's groups have continuously been trying to argue in favor of looking at least at gender inequality, if not the intersections of gender inequality with other forms of inequality. And we've gone from the early days of sterilization, of movements against sterilization and coerced family planning, to concerns around contraceptive technology and surrogacy, to more complex the more complex interplay between caste and gender, the concerns around safe abortion and maternal deaths, and the treatment, the respectful treatment or not, the disrespect and abuse of women in obstetric wards. And yet, although the women's groups have played a stellar role in pushing for these agendas and trying to bring them into the mainstream, I would argue that they still remain on the sidelines, both of public policy, as well as, sadly, even within social movements. Let me move on now quickly to my concerns around biopower. The conceptual, and what does biopower have to do with all of this? The conceptual framework of biopower and biopolitics helps us understand both causes and consequences of inequality in public health. The terminology of biopower and biopolitics, of course, dates back to the French philosopher Michel Foucault and his writing. And Foucault talked about how in the modern era, in a nutshell, governance by the state has been transformed from the power to kill transgressors to sustaining life and determining who should be allowed to die. From more visible controls over rebellious populations to more invisible controls through regulations, standards, norm setting, and so on. Foucault argues, and I don't have time to get into Foucault's argument here, that the scientific discourses of biomedicine and public health have a great deal to do with the rise of biopower. Let me say two things. I'll say two things in this context that are of importance for us, and then I'll give you an example from the Indian case, which before I come to a couple of points about the current time. One thing is we all tend to think of public health as a public good, as undeniably, unchallengeably a public good. And yet for Foucault, there can be a dark side to this public good. And that can come through an example of the following kind. And let me give you the example of smallpox eradication in India. Some of you may have heard me speak about this, but I think it's too good, too brilliant an example not to put before this audience. Around 1950, right after independence, India had about 160,000 reported cases of smallpox, with a case fatality rate of about 30% or so. And there was, in the early days, there was no cure, no vaccine. It was one from which if you got it, your chances of living and dying were very iffy, and so on. And the Indian strategy in the first years, from about 1962 to 1972, was mass vaccinations. But however much mass vaccination was done, and of course people tried to avoid vaccinations because there was a fear of immunization. But even despite that, mass vaccinations simply didn't seem to be reducing the rates of smallpox during the smallpox season each year. But between 1972 and 1977, the approach completely changed. And instead of mass vaccinations, the approach shifted to one of surveillance and containment. Large teams of health workers, literally hundreds of thousands of health workers, went on house-to-house searches on a mass scale throughout the country. The approach was heavily data-driven. Each monthly search during this period would generate something like 8 tons of forms. There was a lot of IEC, information, education, and communication, but there were also incentives. Incentives for what? Incentives for pointing health workers to households which may in fact be housing a smallpox case or cases. So telling on your neighbors, surveillance on your neighbors, 100 rupees per case reported. And when I saw this, I was really struck, because that looked so much like what happened very shortly thereafter during the emergency. Nonetheless, this was a highly successful program. By 1975, the last Indian case of smallpox was found, and in 1979, WHO declared that smallpox had been eradicated. A very short time to do something very quickly. The problem was, of course, a couple of years later, in fact, the same year as the last Indian case of smallpox, we had the declaration of emergency. And we know what happened with sterilization during the emergency. The same tactics and approach used, modified but used in smallpox eradication were applied in the family planning program. And I don't need to detail for you the extremely problematic consequences in terms of human rights and other violations with which we continue to live till today. We cannot get vasectomies done, and the reliance on female sterilization, the continued reliance on female sterilization, despite all of its problems, continues till today. We also know the distortionary impacts this had on the work done by health workers in the field, by the A&Ms, incentives, disincentives, and so on. So the biopower points us to the potential dark sides of public health as a public good. And you might say that tough times call for tough measures. And it's too bad, but what can be done? The problem, of course, is here's where inequality kicks in, because the tough measures don't apply uniformly to everybody in a highly unequal society and economy. Public health measures in a highly unequal society can become draconian for those at the bottom. I'm talking here not just about all of the nonsense about COVID jihad, which we've seen and which now thankfully the courts are bringing to account, but also the casual violence that many of us would have seen of the policeman who was recently beating up this young lad who said he was out searching for food in the night. But what struck me when I saw that video was how casually the beating with a large cane of this young boy took place. It was very casual, normalized. This is the way we treat people like this. But in addition, we all know the lockdowns, the impact of the lockdowns on informal workers, the rising hunger that is now emerging from evidence in the field by many who are in the field and can observe this, the rising hunger and starvation deaths despite overflowing food stocks, no cash transfers, even though no less a person than Martin Wolf, the editor of the Financial Times, has said that India can perfectly well afford fiscally Financial Times, mind you, the capitalist paper, if ever there was one, Financial Times editor said India can afford to spend on this, just give the money out. You need to hold up demand and you need to keep people from starving. But we haven't been able to bring ourselves to do that. The rising violence against women pandemic, which is hardly spoken about, the challenges that women health workers at the bottom of the health worker pyramid face in terms not only of their shifts and safety, but the access to equipment and the ability, in fact, to do their jobs without significantly elevated risks. This toxic mixture of economic and social inequality, and we know who is at the bottom of the social hierarchy here. Caste plays a severe role, gender plays a severe role, religion is implicated, and we know that these are our original sins that come home to roost in a pandemic type situation through the workings of biopower. Let me then just quickly summarize what I've tried to say here. I've made 4 basic propositions. The first, that economic inequality, as is well known, affects health negatively, no matter which manifestation one looks at of health. Secondly, social inequality matters and cannot be subsumed under economic inequality. It has independent and variable effects that must be understood and that must be addressed head-on. Third, understanding the workings of biopower and the fact that public health can have a dark side, especially in a highly unequal society. And finally, that inequality and biopower in that dark side actually amount to what I would call a perfect storm. Thank you very much. Thank you for your attention, and I look forward to the discussion.
Thank you, ma'am, for the extremely captivating, thought-provoking, as well as awe-inspiring talk. I would now like to request Dr. Prashant N.S., Assistant Director Research at the Institute of Public Health, to take over the moderation of the discussion and close the session.
Thank you. Ma'am, I hope I'm audible to you.
Yes, you are. Thank you.
On YouTube Live, there have been some comments and questions that are coming through, and I will take the opportunity to transmit some of them orally to you as we speak and invite your thoughts and remarks. Since this is streaming live, I request if we could extend from 5 p.m. to maybe 5:05 or 5:10, depending on the nature of comments, if that's okay with you. Firstly, there is a comment here, ma'am, about you mentioned about societies which have over time, and you conceptualized this very well for us, the idea of the original inequality sins of various societies, and you even gave examples. So there's a question here on how have these societies, in your view, addressed these, and have there been differences? Are there perhaps lessons, implications for us in India? Thoughts on that?
Do you want to do question by question?
We can take, yeah, I can give you about 3, and let's see based on time. If there are more, we can come back. There's another line of a few comments about, this is largely from colleagues in IPH. What would be the implications of your strong message for public health organizations like IPH, which are somehow straddling academia and on ground, and would like to be held accountable for the academic outputs in terms of societal impact. Not only IPH, but such there are a few of these, and one always wishes there would be many, but there are a few. What would be the message from you to IPH and IPH-like organizations, straddle academia and on-ground action? And maybe a third one, given that there are a lot of early career researchers, probably many of them walking into public health with a wish to do wider good. What would be your message to people who are early on in their PhDs, framing research questions and seeking to do research for societal transformation? Maybe with these three, we could hear your thoughts.
Yeah. Okay. How can societies address their original sins? And as I tried to say, not all have the same, not all have as severe original sins as some do. Some are much worse than others. And some are in the lucky position of not having gone through histories that lead them with huge reservoirs of inequality, social inequalities, so to speak. If I were to think in terms of how societies address those original sins, I think societies need to tackle the implications and the nature of those sins head on. Now, that becomes, of course, very complicated. And before I come to India, let me give a couple of examples of societies that have tried. And I'm by no means trying to say that this is easy by any means. I mentioned 4 countries where indigenous people, the original inhabitants, had received a raw deal: the US, Canada, Australia, and New Zealand. Among all those 4, the US probably is the worst. After putting them into reservations, all they seem to have managed to do is allow the private sector to run rampant in terms of setting up casinos in those reservations and allow them to become environmental dumping grounds. As a consequence, the rates of alcoholism, drug abuse, and so on in those areas is very, very high. Canada is only marginally better, but Canada, and in Canada, we're now in recent years have been seeing the phenomenon of huge numbers of unaccounted deaths among young Native Canadian women, what they call the First Nations women, just disappearing and then being found dead later on. Probably the country that has done the best is New Zealand, where through explicit recognition, not of them as poor, vulnerable, and so on, but taking on the indigenous society, Native New Zealanders, the Maori, as a culture that was a central and important part of the culture of New Zealand, to the point, I'm sure many of you are aware at least, of the fact that official New Zealand greetings are all through the Maori tradition. Maori forms of greeting are what the Prime Minister of New Zealand will use when visitors come to visit her. So at the highest levels, the recognition and its very leadership is critical. And leadership at the highest levels, as we know, sets the tone for the rest of the country. We certainly know that from the experience of the United States, and we certainly know that from the experience of many other countries. But it's also true on the good side from the experience of a country like New Zealand. So the feelings among the Maori population, seeing their prime minister greeting others, dignitaries, using Maori greetings, is bound to have an effect. Now, this is obviously not the only thing. There are many other elements in New Zealand, but the ability and the willingness to recognize the original sin and to deal with the original sin is crucial. Now, in our context, of course, the issue of caste has been terribly confused and muddied over the decades, as we know, to the point from initially imagining that we could just do away with counting caste in the census and that would somehow remove caste-based behavior and thinking. Well, all it did was to make it very difficult to know what was actually going on in the name of caste. Through, of course, all of the corresponding, all of the later effects, the Mandal Commission, etc., as we know. But the importance of the tone and the approach set at the highest level is one that I would critically mention here. However terrible it may be, it matters and makes a difference. Now, sometimes, of course, it can also lead in a viciously unequal society, it can lead to backlash. And that, of course, was what we have seen in the US, for instance. The backlash against having an African-American president is one that not only the US, but the whole world has been living with since then. So these things are pushes and pulls. It is not easy, but it certainly is not something that one can hide under a rug and hope that it will somehow disappear. Similarly, I would argue for gender. Gender, of course, is a different kind of inequality, but it never receives. In country after country, think of who gets made minister for gender affairs. Think of how much money gets allocated to the women's ministry and women's machineries, so-called. And that will tell you how poor or how weak the commitment at the highest level is to getting rid of gender inequality. So I would say that in terms of the original sense. Your second question was the implications for public health organizations like IPH of what I'm saying in terms of both academics and action. My argument, I think, is basically this, is twofold. One is there is inequality beyond economic inequality between households. And it's way past time that we stopped automatically thinking of inequality as the economic inequality between households. If we don't research it, we'll never see it. How would we? We wouldn't. And it gets masked. Economic inequality masks other forms of inequality, as in the example that I gave. So I would say that it's extremely important that organizations really start focusing on the intersectional nature of different kinds of social and economic inequality, developing the methods, developing the empirical evidence, and understanding what it is that we are actually up against in this regard. And I would say similarly, of course, in the straddling of action, we need as well to be aware of what that will mean on the ground. It's not easy, and I would be the last person to say that it is easy. In our own work in Koppal, for instance, one of the most difficult things that we found to tackle was the issue of caste. You can't treat the issue of caste head on when you are, as anyone who works on the ground knows, it's very difficult to take it head on when you're actually working in the field on public health. But there are many ways in which one can do it otherwise, and one certainly needs to problematize it, at least, and be aware of it in terms of work. What's my message for early career researchers? For early career researchers, I would simply say, listen, there is a huge amount to be done in this area. Those of us who've been working in this area still feel out, despite decades of work, that we are still only scratching the surface, that we're in a sense on the frontiers, and and keep looking to see who's behind us to be following in interest on these issues. But let me also say that if we don't address inequality, and if we don't address how biopower works, our programs and policies will keep running afield. They will not work in the ways that we want them to work. Okay, don't know if we have time for more, but I'm happy to take a couple more if you have them.
If you permit us one more round, there is certainly a lot. I will not. I will try to pick up themes that have emerged across questions and maybe share them. And if you could share your thoughts, we promise to end in 5 to 10 minutes.
Sure.
One theme that is coming up here is about rethinking ways in which we study spatial inequalities. And there are people who have shared some interesting resources. Abdullah's paper on rethinking spatial inequality in development, for example, has been shared. I'll just let that be as a comment. A second one has been about politicization of how politicization of inequality also has differing consequences for it itself, and perhaps how we could address, deal, engage with that topic. There's been a bit back and forth between participants on that.
Can you just say, Prashant, can you just say what the two sides on that are? What is being said?
So from what I can see here, one comment says, would want to know your thoughts on politicization of such inequalities, such as caste-based reservation, income guarantee schemes for specific populations, etc. And also inequalities within cadres of health workers, etc. So it's a swathe of topics being talked about, but I guess what people are asking about is what have such what has politicization achieved, positives and perhaps also trade-offs from such efforts. Then third one is, I think, some comments from colleagues on what you said earlier about how countries have addressed the original inequality sin. To what extent, and this is also something that's really close to my heart from the work that we do on tribal health. Why do you think, ma'am, that in India we have not been able to create a more wider public acknowledgement, firstly, of our own historical and social injustices? What would your thoughts be on how we can advance towards a wider acknowledgement, forget even addressing a thorough acknowledgement of this injustice, and then move the conversation forward? These and any other thoughts that come to your mind, this will be the last iteration that we will have in this oration.
Okay. So, the politicization of inequality. It's a bigger question than the question of caste-based reservations and economic reservations, etc., etc. What have they accomplished, not accomplished, etc., and so on. If I start talking about this, we'll be here for another 5 hours, which I'm sure nobody wants to do. And certainly, I'm not trying to belittle or minimize the question. That's what I meant when I said that in our own context, how we've handled this has such a long and complex history that cannot be ignored. However, think of all the things that we haven't done. One of the things that we haven't done is in education. If we think about how much we understand about society, social divisions, the origins of caste, the nature of gender inequalities in our school education, it's hardly surprising that we then end up with this why them, why not me approach, as well as this attempt, as well as this belief that somehow if you provide caste-based reservations, you are in fact going to resolve the problem. How does that do away with the huge forms, the natures of caste-based inequality that we know? What actually have we done about manual scavenging in this country? In this country, 75 years after independence, almost, we don't have the technology. We can't put an end to this if we set our minds to it. What does this have to do with reservations? Nothing at all. Why can we not? Where is the leadership that shows that you cannot treat other human beings in this way? So we have, in a sense, tried to use administrative and bureaucratic measures. I'm almost tempted to say biopower type methods, regulations and rules to make up for genuinely transformative change, which comes through education, understanding, leadership, and knowledge building, and the importance of children. Some groups in society very well understand today the importance of education. They're not necessarily the groups that I would agree with, but we need to know that we cannot know. We do not know. In our schools, children grow up entirely unknowing about what caste means, and grow up then believing that, oh, I didn't see any discrimination. It isn't there. So this is just mollycoddling going on. This reservation needs to end. What matters is economics. And that's, of course, because you've never been exposed to it. You've never understood it. You've never been taught it. You've never had to learn it. And I think that for me is far more important at this point. Social movements are crucial. And of course, as we know, the Dalit movements have been trying very ardently to move this agenda forward. But we are, I would say that if there has to be let there be a genuine politicization of inequality, which is based on a genuine understanding of our history. Now, a cynic might argue that this is not exactly the best time in our own history to be calling for the politicization and understanding of our own history. Perhaps not. But then, nothing venture, nothing gain. And we'll see where that goes. Finally, why is there no wider acknowledgement of injustices? I think it's the same reason: education. Absolutely lack of education. We set about building temples of modern India. The temples of modern India should have been the schools. Not dams and bridges, they needed to have been the schools, where in fact we would have understood coming out of. But I think, the traumatization of independence itself and the partition, there was probably this desperate desire to go beyond and look at things that might seem to be less, quote unquote, politicized. But we also know that the similar political dispensations to the ones that we are dealing with in society today existed at that time. And the Constituent Assembly debates were not, all smoothness and light by any means. But I do think that but I don't believe that it's too late. I believe that this is a process that can always happen and can always begin. And it's important, and for young people particularly, it's extremely important that to be a part of the movement for justice. And that there is always, there is nothing like the best time or a good time for justice. All time is a good time for justice.
Thank you, ma'am. Thanks a lot. And with that, I think we've had a fair share of question and answer and interaction time with you as well. And I think I will not attempt any kind of summary of the wealth of insights that have been shared today. But I would like to emphasize that a lot of what you have said is something that we at IPH, and I invite others who have joined this oration and others who will listen to this later to also join in this effort at a wider acknowledgement and perhaps a collective dialogue on various aspects of social inequalities that have been shared today. And we hope that many of us can join together, build coalitions and take forward this agenda and research and action. With this, on behalf of my colleagues at the Institute of Public Health, we all thank you so much for having delivered the 2020 edition of the IPH Annual Day Oration. This joins an archive of annual day orations and orators that we hope to curate over the years and to contribute to building a knowledge base and a dialogue base on action on strengthening health and health inequalities. Can I request, of course, if we were in person today at the Institute, we would have handed over this plaque to you. Sadly, the times are different, and as a token of handing over the plaque to you, I hope you're able to see the plaque of the 2020 IPH Annual Day Oration. On behalf of the director, on behalf of the governing board of the Institute, and on behalf of all my colleagues, it's my honor to hand over this plaque. Of course, it will be delivered to you in person. Thanks a lot, ma'am. And if you have any final remarks, you may please proceed.
Yeah, no, I just wanted to say thank you very much once again for inviting me to do this. It's been a great honor and pleasure. Thank you to the participants for really interesting questions. And I look forward to a continuing debate on these issues. Thanks very much.
Thanks a lot. And with that, we have now come to the end of the 2020 IPH Annual Day Oration. On the screen, you have various ways in which you can continue to follow our work at the Institute. And we invite you to join and interact with us on these. Please note that the oration video will be made available on YouTube and will be shared. And so we invite you all to share the message delivered in the oration and use it as a conversation starter on social inequalities and see how these dialogues can also bring about transformation in our own smaller context. Thanks a lot for joining us and wish you all a good day.